We will start the session in another 1 minute. Good evening, everyone, and welcome to today's masterclass on making the correct diagnosis of diabetes. I'm Priyanka Jain, along with my colleague Kritika Monga from Marketing Department, Elsevier, India. We will be moderating the session today. Before we start, everyone else will be on mute during the session. You can post all your questions in the Q&A tab on your screen. These questions will be addressed by our speaker in the session. With this, I would now like to introduce our esteemed speaker of the day, Professor Mark Strachan. Professor Mark is a consultant physician in endocrinology, diabetes, and acute medicine at the Western General Hospital, Edinburgh, and an honorary professor of the University of Edinburgh. He studies at the university where he graduated with BSc in 1990 and MBc in 1992. He was awarded an MD in 2001 for studies on recovery in adults with type 1 diabetes. He was appointed a consultant physician at the Western General Hospital in Edinburgh in 2002. And then he became a fellow of the Royal College of Physicians of Edinburgh in 2004. He has a busy clinical practice with a particular interest in pituitary disease, thyroid cancer, and neuroendocrine tumors. He is the secretary of the Royal College of Physicians of Edinburgh and a former member of Council of the Scottish Intercollegiate Guidelines Network. He has been a trustee of the British Thyroid Foundation since 2009 and was appointed treasurer of the charity in 2014. He is trustee of the Anne Edgar Charitable Trust, which provides help and support to the patients with neuroendocrine tumors and their careers. His major research interest is in cognitive impairment in type 2 diabetes, and he is one of the principal investigators of the Edinburgh Type 2 Diabetes Study. He has published over 100 original articles and book chapters. He gave the R.D. Lawrence Lecture at 2010 Diabetes UK Annual Professional Conference. He is editor of the award-winning book Davidson's 100 Clinical Cases in Medicine and has co-authored a pocketbook on insulin. In 2015, he joined the editorial team of Davidson's Principle and Practice of Medicine. We welcome you, Professor Mark. Thank you for joining us today. I now hand it over to you to take this session forward.
Okay, thank you very much, Priyanka. It's an enormous pleasure and privilege to be speaking to you all today. And I just hope that the technology works and that you can hear me all right and you can see my slides. So what I want to talk to you today about is some strategies on how to make the correct diagnosis of diabetes. Now, on the face of it, that's a pretty simple thing to do, because we all know that in order to diagnose diabetes, all you need to do is demonstrate an elevated blood glucose level. That can either be a random glucose, a fasting glucose, or indeed an elevated hemoglobin A1C. And the figures that will be familiar to many of you are shown on the slide here. And in fact, this table is taken straight from the 23rd edition of Davidson's. But that's making a diagnosis of diabetes. But what is also important to consider is why that person has diabetes in the first place. What is the underlying diagnosis? What is the underlying cause? Now, when it comes to diabetes, of course, it's all about insulin. Diabetes is either a consequence of an absolute deficiency of insulin or resistance to the action of insulin, or very commonly, a combination of the two. In terms of the underlying reasons why somebody might be insulin deficient and or insulin resistant, and as you know, it's usually a combination of both genetic factors, so an inherited tendency to diabetes, I'll discuss that in more detail later, and one or more environmental factors. When it comes to environmental factors, of course, we know what many of these are, but many other environmental precipitants of diabetes we're entirely unclear about. So, of course, we all know that type 2 diabetes in its classic form is strongly linked to obesity and is related to the environmental factors that lead to obesity. We know that there are drugs and toxins that can have an effect on the onset of diabetes, such as alcohol. And then when you think about things like type 1 diabetes, we're certain there must be an environmental precipitant of type 1 diabetes, and we think it may be exposure to a viral infection at some point or some other stimulus, but we don't really know for certain. But that combination of genetic susceptibility and environmental factors is very important in the etiology of most forms of diabetes. Now, the differential diagnosis of diabetes is actually very, very broad. So clearly, type 2 diabetes is the most common cause of diabetes in virtually all societies across the world. And that, of course, is strongly linked to obesity. But as you know, there are many other forms of diabetes, type 1 diabetes, so-called secondary forms of diabetes, and rarer genetic forms where you are inheriting a single gene defect. So it's one inherited gene abnormality, inherited usually in an autosomal dominant fashion, the so-called monogenic diabetes. So if we just look at secondary forms of diabetes, first of all, now these are relatively uncommon, certainly in the UK. But of course, if somebody has had damage to the pancreas gland for whatever reason, either by virtue of the fact that it's been removed surgically, or by trauma, or by cancer in the pancreas gland, or particularly common in UK, alcohol exposure, iron overload hemochromatosis. This is a chest X-ray of somebody with cystic fibrosis. And here is an X-ray of somebody with chronic pancreatitis. And of course, with some rare forms of diabetes that are thought to be related to malnutrition, such as the fibrocalcific pancreatitis. Diabetes can also be secondary to endocrinopathies, and usually these cause or precipitate diabetes because they increase insulin resistance. So here's a man with acromegaly, growth hormone excess, a woman with Cushing's syndrome, cortisol excess, and this is a scan showing a pheochromocytoma of the left adrenal gland. In fact, you can just see the left adrenal gland there with the tumor arising from it and the spleen sitting on top. Again, these are rare causes of diabetes, but if you don't think about them, then you won't diagnose them. Another very common secondary cause of diabetes is drug exposure, and in particularly steroid, in particular glucocorticoid exposure, such as prednisolone and dexamethasone. And again, that stimulus is occurring primarily through an increase in insulin resistance. The monogenic forms of diabetes are sometimes known as maturity onset diabetes of the young, or MODY. It's quite a cumbersome title, but it basically relates to the earliest descriptions of this form of diabetes in the 1970s. And in fact, this was the first family shown in this photograph where monogenic diabetes was identified. And it was a very wise, very eminent diabetologist working in Nottingham called Robert Tattersall that first described MODY. And what he noted in this family was that diabetes occurred at varying different ages, and the ages are shown on the slide here. And that it seemed to be inherited in an autosomal dominant fashion. So there were 3 generations in this wedding photo. Need insulin treatment. They could be managed very often with tablets alone. And so that's where the term maturity onset diabetes, which then was the name for type 2 diabetes, which was traditionally managed with tablets, but it was occurring in young people, not older people. And of course, as time has gone on, we've better understood that the various forms of monogenic diabetes are caused by a single gene defect that alters beta cell function, usually reduces beta cell function. And about 1 to 2% of all people with diabetes, certainly in Western societies, have an underlying monogenic form. We now recognize that over 30 different genetic causes of monogenic diabetes. The commonest of them is HNF1 alpha monogenic diabetes, with glucokinase the second most common. Type 1 diabetes, as you will know, usually presents in childhood or young adulthood, but actually can present at any age. The presenting history is normally very short, period of weeks, with floridosmotic symptoms and weight loss, and usually you can detect either ketones in the blood or the urine. And of course, if the diagnosis is delayed, then ketoacidosis can develop. Now, type 1 diabetes has this classic genetic and environmental predisposition. There is a very strong genetic predisposition, which I'll show you in a second, which is linked to HLA haplotypes. So basically, what you're inheriting from your parents is an immune system that isn't just quite primed in the same way. So that if you experience the environmental trigger, be that a viral infection or some chemical toxin, whatever that environmental trigger is, because of the nature of your immune system, that will trigger an autoimmune response. And that autoimmune response can be detected by measuring antibodies in the blood to GAD, glutamic acid decarboxylase, insulinoma antigen 2, IA2, and zinc transporter 8, ZNT8. Now, these antibodies aren't causing the autoimmune destruction. They're just markers of the process. Now, the reason that we don't really know what the environmental trigger is to type 1 diabetes is that it almost certainly occurs several years before presentation, or in the case of very young children, several months before the presentation. So that environmental trigger in a genetically susceptible person causes progressive autoimmune destruction of the islet cells, particularly the beta cells, which reduces insulin secretion, and then you get to a tipping point, typically when around about 80% of the islets have been destroyed, when diabetes will declare itself. The genetic predisposition to type 1 diabetes is just sort of identified here in this slide. So you can see that if you have a father who has type 1 diabetes, then you are 9 times more likely to get type 1 diabetes yourself. If both of your parents have got type 1 diabetes, then you're 30 times more likely to get type 1 diabetes. So there's this strong genetic component to type 1 diabetes. The environmental factor, as I say, is unknown. One of the things that makes people think it may be viral related in some way, or some infectious precipitant, is that there is quite a marked in Northern Hemisphere, a north-south gradient in terms of susceptibility to type 1 diabetes. So type 1 diabetes is much, much more common in Finland than it is in Greece. And you see the opposite pattern in Southern Hemisphere countries. Now, as you all know, type 2 diabetes is by far and away the most common form of diabetes. In predominantly Caucasian populations, type 2 makes up about 85% of all diabetes. But in non-Caucasian populations, it's up to 95% of all diabetes. Genetic factors, as I'll discuss in a moment, are hugely important in type 2 diabetes, and that in part explains the predilection for type 2 diabetes that we see in many different racial groups. So you'll know that people of South Asian origin, people of Polynesian origin, people of Afro-Caribbean origin are more likely to get type 2 diabetes than Caucasians. There is also a strong association with increasing age. So older people get type 2 diabetes more commonly than younger people, and with central obesity. Low birth weight is also associated with an increased risk of type 2 diabetes. The association with increasing age and obesity is, they are actually linked quite tightly together. So the more overweight you are, so in this graph here, this is BMI on the x-axis and age of onset of diabetes on the y-axis. And you can see that people who are extremely overweight, body mass index of 40, will get diabetes at a very young age. And of course, we're seeing, for example, in some American cities like New York, people of Afro-Caribbean heritage getting diabetes, type 2 diabetes in childhood. Whereas if you've got a body mass index of 25, you may not develop type 2 diabetes until you're in your 60s. So basically, the more overweight you are, the earlier the onset of type 2 diabetes. We all know that type 2 diabetes is strongly linked to central obesity because that is associated with insulin resistance. So the more insulin resistant you are, the more likely you are to get diabetes. And of course, that central obesity is also associated with hypertension and abnormal lipids, particularly high triglycerides and low HDL cholesterol. But if I said to you, how would you define type 2 diabetes? It's actually something that is quite difficult to write down on paper. And we often end up saying things like, well, type 2 diabetes is what happens in older people and people who are more overweight, and it's associated with insulin resistance. And they don't have type 1 diabetes, they've not got a secondary form of diabetes, and they don't have a monogenic form of diabetes. So type 2 diabetes almost tends to be a diagnosis of exclusion. You're happy that they don't have one of the other forms of diabetes, and you know that it's associated with the various risk factors. But there is groups. can present with ketoacidosis, and require initial treatment with insulin, but thereafter can be managed with tablets. And that's called so-called flat push diabetes. Another problem is that often used to bother me in a way is that you will sometimes see people with an extremely high body mass index, 45, 50, weighing 150, 160, 170 kilograms, and yet they're not diabetic. And I always just think, well, why is that? How can that be? And yet on the other side of the coin, you'll see people with a body mass index of 23 or 24 who clearly do have type 2 diabetes. They don't have type 1, they don't have monogenic diabetes, they don't have secondary diabetes, they've got type 2 diabetes. So how can you explain that paradox? Well, the paradox can be explained if you clearly understand what type 2 diabetes is. Now, we've discussed the environmental in effect, but type 2 diabetes has a very, very, very strong genetic component. In fact, about 40% of the overall risk of type 2 diabetes is determined by genetic factors. And in fact, there are over 400 different genes that are associated with an increased risk of type 2 diabetes. Now, we all have these genes, but we just have subtle variations in each of these genes that increase or decrease our risk of type 2 diabetes. But you can see again with the family studies how strong the genetic component is. Now, if I said to most people, well, okay, we know there's a genetic component to type 2 diabetes, but what is the nature of that genetic component? I would imagine that most people would say, well, it must be to do with obesity or insulin resistance. You're inheriting a tendency to be overweight if you've got plentiful access to food, or you're inheriting a tendency to being more insulin resistant. And in people of South Asian origin, there is an element of that. We know that, and you will know that for a given body mass index, people of South Asian origin lay down fat more centrally than peripherally. And that central fat is associated with more insulin resistance. Now, that tendency to lay down fat centrally is genetically determined. But actually, if you look at these more than 400 genes that are associated with type 2 diabetes susceptibility, the vast majority of them relate to beta cell function or beta cell mass. So what you inherit from your parents is a pancreas that either produces lots of insulin or a pancreas that doesn't produce very much insulin at all. Now, that doesn't matter if you're slim, but as you get older and as you put weight on, if you've got a pancreas that is not quite so good, then you will develop diabetes at an earlier age. Now, let me try and just illustrate this point a bit more just with a series of graphs. Now, these graphs are not based on any data. This is a very idealized, stylized graph. But what I'm showing here on the x-axis is increasing age, and on the y-axis, levels of insulin in our blood. And this dotted line represents the threshold that if you fall below that line, you're going to become diabetic. So if you drop below that dotted line, you'll become diabetic. Now, at birth, we start off with the maximum amount of insulin that we're ever going to have in terms of insulin producing potential. And actually, one of the features of aging is that our pancreatic function declines. We produce less insulin as we get older. That's a normal part of getting older. What this graph shows is that actually, if you live long enough, we'll all get diabetes. So You may have to live until you're 120, but if you live long enough, you will eventually produce, your insulin production will fall to such an extent that you'll cross the threshold and you'll become diabetic. Now, the age at which that happens is determined by where you start off, and that's genetically determined. So if you inherit from your parents a high susceptibility, genetic susceptibility to type 2 diabetes, what you're inheriting basically is a lower beta cell mass, or cells that are just not able to produce as much insulin. And so you start off life with less insulin, and even if you decline at the same age as everybody else, you will cross the threshold for diabetes at a younger age. If you're really unlucky and inherit a really terrible pancreas from your parents, you will cross that line at an even younger age. If you are exposed to environmental factors that accelerate the destruction of beta cells, then you will also develop diabetes at a younger age, even if you're starting off with a really good pancreas. So if, for example, you drink lots of alcohol and give yourself chronic pancreatitis, you will accelerate the decline in beta cell function, and you'll develop diabetes at a younger age. If a surgeon comes along and removes your pancreas, you may be at this point here with a normal pancreas, and then suddenly you'll go down to 0 and you'll have no insulin. If you become more overweight, then, and I'm going to toggle back to the previous slide. If you become more overweight, the threshold at which you develop diabetes, the insulin threshold, actually rises because you're becoming more insulin resistant. And so that means even if you've inherited a good pancreas, then you will develop diabetes, say if you're overweight in your 60s and your 70s. But if you've inherited a pancreas that's not so good, then it may be in your late 40s that you get diabetes. And if you become really overweight, if you become really overweight, then you will again develop diabetes at an earlier age, and at an even earlier age if you have inherited a pancreas that's not so good. So what I'm hoping I'm trying to explain with these graphs is that the age of onset of type 2 diabetes is determined by how insulin resistant you are, which is mainly an obesity factor, which is predominantly lifestyle, but a bit of genetics, and is also determined by your beta cell mass at birth, or beta cell function, and whether or not there's any accelerated decline in insulin. So you can see that if you have inherited a strong genetic tendency to diabetes from your parents, so you've not got a good pancreas, and you become really overweight, that's when you get diabetes when you're 15 years of age, and that's what we're seeing in your whole life. And you've inherited a really good pancreas from your parents, then you might not get diabetes until you're 110. So this explains some of the paradoxes that I mentioned earlier. So if you've got a BMI of 45 and you're non-diabetic, the reason is because you've inherited an amazing pancreas from your parents. You've inherited a pancreas that no matter how insulin resistant you are, you can produce enough insulin to overcome that insulin resistance. By contrast, if you develop type 2 diabetes in your 50s and you've got a body mass index of, say, 23, that's because you've probably inherited a pancreas from your parents that really wasn't very good to begin with. You didn't make that much insulin. And as you've put a little bit of weight on as you've got older, and as your pancreatic function has naturally declined as you've got older, you've then crossed the threshold. And as you've seen from the graphs, type 2 diabetes can be a result of insulin deficiency or insulin resistance, or indeed in most people, a combination of both. So what I hope you've also seen is that actually trying to work out why somebody is diabetic at first glance. So it's very easy to mislabel or misclassify the underlying cause of somebody's diabetes. So we normally diagnose type 1 diabetes in young people if there's a history of weight loss and if we detect ketones in the blood and if they've got positive antibodies. So if this young chap came along with ketoacidosis and had really strongly positive GAD antibodies, then yeah, you know for certain he's got type 1 diabetes. Conversely, this gentleman came along, he's very overweight, he may also have high blood pressure, he may have a dyslipidemia, he's got no ketones, and if you've measured antibodies, and there may not be any need to do that, they're all negative, then you might be able very positively to make a diagnosis of type 2 diabetes. But there are potential pitfalls. Now, these statements in black here are all wrong. So I always believed for a long time that ketosis only occurred in people with type 1 diabetes. Well, that's not true. People with type 2 diabetes can get ketoacidosis. I gave you the example of the people with Flatbush diabetes earlier. Type 1 diabetes only occurs in children and young adults. I've seen many people in their 60s, 70s, and 80s present with absolutely definite type 1 diabetes. Diabetes in an overweight person must be type 2 diabetes. Well, that's wrong, because if you use weight alone as a discriminator in terms of the type of diabetes, you can be wrong, because there's no reason why autoimmunity cannot occur in an overweight person. So an overweight person is as likely to get type 1 diabetes as somebody who's slim. Similarly, diabetes in an older person isn't automatically type 2 for the same reason that I said earlier. And this is another one just to remember if you're measuring diabetes antibodies. So again, I've always believed that if you've got even a very weakly positive antibody, one antibody, then that means that that person's got type 1 diabetes. But actually, low titers of antibodies can be observed in the general population and are not pathogenic. You can actually also get false positives. So you can have somebody with moderate titer of antibodies and it's not pathogenic. All you can say is that the higher the titer and the more different antibodies that are positive, the more likely it is that the person has got type 1 diabetes. Now, this is Theresa May, who some of you may know used to be the Prime Minister of the United Kingdom. Now, you can see that Theresa May has diabetes. She's wearing a Freestyle Libre continuous glucose monitor on her arm. Now, Theresa May is an example of somebody whose diabetes diagnosis was erroneous. So Theresa May was diagnosed with diabetes, just on the basis of high blood glucose levels, but she was diagnosed as having type 2 diabetes. Now, why was she diagnosed as having type 2 diabetes? Because she was in her mid-50s when she was diagnosed. So the doctor that saw her said, oh, well, you're an older person, you've got diabetes, it must be type 2. And she endured a year of pretty poor glycemic control on tablets, and before the penny dropped and it was realized that actually she had type 1 diabetes. And here's a patient of mine called Sophie. Now, Sophie was diagnosed with type 1 diabetes at the age of 8 back in 1990. Now, she remembers losing weight and being very thirsty, and her glucose level was around about 17 when she presented, 17 millimoles per litre. And she started on an insulin therapy. And throughout her young adulthood, her diabetes control, like many young people with type 1 diabetes, was not very good. And as a consequence, she has developed complications of diabetes. In 2007, she was noted to have background retinopathy and microalbuminuria. And by 2015, that had progressed such that she had proliferative retinopathy that needed laser treatment. In 2007, she undertook a DAPHNE course, a structured education course, and in 2015, she was put on an insulin pump. Oops, my slides have gone a bit funny here. Sorry, I'm having a slight technical issue. Bear with me, and I should be coming back now. There we are. So in 2016, Sophie became pregnant, and the pregnancy was an absolute nightmare for her. She developed multiple bleeds in her eyes due to vitreous hemorrhaging. And during that pregnancy, we were notified by another diabetes team that Sophie's father, who was also diabetic, had actually been found to have a monogenic form of diabetes due to an activating mutation in a gene called ABCC8. And we did genetic testing in Sophie, and she was found to have the same mutation. Now, this is Sophie's blood sugar control. This is just finger prick blood tests. And you can see her control is not good at all. This was on insulin. Her average blood glucose was 9.7, but like many people with type 1 diabetes, very wild swings in blood sugar levels. Sophie went on to have her baby, and we tested her baby, and her baby did not have the gene mutation, but we knew that that ABCC8 form of monogenic diabetes was one that could be managed with sulfonylureas. It's a sulfonylurea sensitive form of monogenic diabetes. And I started at the end of 2017, started Sophie on glycoside, later added in sitagliptin, and just under 2 weeks later, she was able to switch off her insulin pump device, and she has not required insulin therapy since. And at that point, she had been on insulin for 27 years. And this was her Freestyle Libre download on sulfonylurea therapy. So you can see that she now has near normal blood sugar levels. Now, as a team, we were extremely upset by this because we think we're pretty good at identifying people with monogenic forms of diabetes, but Sophie had never been on our radar as having a monogenic form of diabetes. We always just, she'd been transferred to us from the pediatric practice, and we just believed that she had type 1 diabetes. And it would not be, if I just go back to my previous slide, it wouldn't be an exaggeration to say that if Sophie had been found to have the monogenic form of diabetes 10, 15 years earlier and started on a sulfonylurea at that point, then she would have achieved virtually normal blood sugar levels, and so would not have developed advanced diabetic retinopathy. So Sophie endured 27 years of insulin that she never needed to be on, and she's developed complications of diabetes that she never should have developed. So we recognized that if this had happened to Sophie, then there must be other people coming to our clinic who we believed had type 1 diabetes, but actually we'd got the diagnosis wrong in. And we started looking around to see if there was another way that could help us work out more accurately the underlying cause of someone's diabetes. And that's when we started measuring C-peptide. So as you'll know, insulin is made in the beta cells of the pancreas as proinsulin. And that gets cleaved by beta cell peptidases to release insulin and C-peptide. So you've got the alpha and the beta chain of insulin and the C-peptide. Now, C-peptide is essentially biologically inactive. But what C-peptide provides is a measure of endogenous insulin production. And the reason it is a measure of endogenous insulin production is because synthetic insulin, like Act Rapid or Insulatard, does not have C-peptide in it. So if you've got C-peptide, that means you're making insulin yourself. So we started a program of measuring C-peptide in our patients with who we believed had type 1 diabetes. And in essence, if you have a very high C-peptide, so an R assay over 900, then that means that you're quite insulin resistant and that you have almost certainly type 2 diabetes. If your C-peptide is very low, then that means you're insulin deficient and you have type 1 diabetes. If your C-peptide is between 200 and 900, i.e. you're making significant amounts of endogenous insulin, then you could still have type 1 diabetes, but it could be type 2, or you could even have a monogenic form of diabetes. This is Jurgita, and Jurgita was diagnosed with type 1 diabetes when she was aged 14, managed with basal bolus insulin. And we measured C-peptide in her, and her C-peptide was just over 670. And when we checked her antibodies, they were all negative. And so we screened her for a genetic form of diabetes, and she had HNF1 alpha monogenic diabetes, which is the most common form of monogenic diabetes. And like ABCC8, is also very sensitive to sulfonylureas. And so we were able, on the day I took this photograph of Jurgita, I gave her a prescription for glycoside, and she stopped taking insulin. And she hasn't taken any insulin since. And so she had 10 years of insulin therapy that she didn't need to have because she was misdiagnosed as having type 1 diabetes, when actually she had a genetic form. So we've tested now nearly 1,000 people with who we believed had type 1 diabetes, and 10% of them actually had C-peptide levels of over 200, i.e. with significant endogenous insulin production. Half of these people actually do turn out to have type 1 diabetes. But the other half of them we've reclassified. So that's overall 6.8% of our people we thought had type 1 diabetes have actually turned out to have a different form of diabetes. 44 of them have been reclassified to type 2, and we identified 14 cases of monogenic diabetes. Now, we have already a lot of people with monogenic diabetes that come to our center. So in centers where testing for monogenic diabetes isn't carried out, there probably would be even more cases identified. And as I mentioned, the other thing that our study has shown is that some people with type 2 diabetes, so again, it's generally been believed that if you've got type 1 diabetes, you make no insulin at all. And that's true for the vast majority of people with type 1 diabetes. But actually, some people with type 1 diabetes continue to make reasonable amounts of insulin. And in fact, these people, if you make your own insulin and have type 1 diabetes, then you end up with better glycemic control, less blood glucose variability, and less hypoglycemia. So it's actually very good if you continue to make a bit of insulin. And in fact, there are lots of studies now going on of immune modulating treatments that are being given to people with new onset type 1 diabetes to see if we can preserve residual beta cell function. So the diagnostic criteria that we have for type 1 and type 2 diabetes are not perfect. And what I always say to my own residents here and students is, if you're making a diagnosis of diabetes in someone, always just think to yourself, why is this person diabetic? What's the underlying mechanism that is leading this person to have diabetes? If you've got somebody who's young, has presented with ketoacidosis and has got very strongly positive antibodies, well, it's clear. They've got autoimmunity causing their diabetes, they've got type 1. If you've got somebody that's very overweight, they're not ketotic, they've not got any antibodies, then almost certainly it is type 2 diabetes that they have. But don't just accept a diagnosis if things don't quite fit. And remember that it's very, very easy to misclassify someone with diabetes. This is my final slide. This is Sandy. So Sandy was diagnosed with type 1 diabetes in 1964. So Sandy's had diabetes now for 56 years. And again, on the day I took that photograph, he stopped his insulin treatment because we realized with C-peptide testing that actually he also had a genetic form of diabetes that was sensitive to sulfonylureas. So he's had 56 years of insulin that he didn't need to have. So thank you very much for your attention. Now I'm going to move to the question and answers. And it looks as though there are 55 different questions. So I'm not going to be able to get through all of these, but I shall try and answer as many of them as I can. So Lenovo's asked, does eating excessive sugar cause diabetes? Well, it's not so much excessive sugar in itself, it's excessive calories. So if you, as I showed earlier, become overweight, that will increase your susceptibility to type 2 diabetes. So it's not sugar that causes it, it's calories of whatever form. Two that are similar, so Divya Jampani and Sunil Patel have asked about viral infections as a cause of type 1 diabetes. So the presumption about the viruses in type 1 diabetes is just that, it's a presumption. And some of the viruses that have been thought about are things like Coxsackie viruses. But the problem is that that viral infection may have occurred 5 years before the onset of diabetes. It may just be a trivial infection that at the time passed unnoticed. And so it's impossible in retrospect to identify what that viral trigger was. So Sunil's asked, could you assert that diabetes is classed as a communicable disease? Well, not really, because, well, A, for a start, we don't absolutely know definitively that it's a viral trigger. But B, the virus only acts as a trigger, if it indeed is a virus, in genetically susceptible people. Asa Mishra has asked if long-term use of beta blockers can cause diabetes, and if yes, how? So yeah, there are studies that have suggested that beta blockers are associated with an increased risk of diabetes, and it's thought to be it's thought to be through insulin resistance, but more than that, I actually don't know what the underlying mechanism is. Anna Branch has asked, how does type 1 diabetes change into type 2 in ketosis-prone diabetes? So the important thing here is that type 1 diabetes is very, very specifically autoimmune driven. So that is, when you make a diagnosis of type 1 diabetes, you're talking about the underlying mechanism whereby the person has become diabetic. It's through autoimmune destruction. When somebody is ketosis prone, that is a sign that they are not making enough insulin. That is not a statement of how that has happened. Now, people with type 1 diabetes, autoimmune destruction, are ketosis prone because they are, because the autoimmune process has destroyed the insulin producing cells. But people with type 2 diabetes also can get ketosis, the so-called flatbush diabetics, for example. Now you might say, well, why, how can that possibly be? Well, there's almost certainly two underlying mechanisms in that. One is that they've inherited a pancreas that's just not very good. So they are genetically prone to have lower levels of insulin than in the general population. If they become overweight and cross a diabetes threshold, but it's not diagnosed, they may then get osmotic symptoms. And if they start drinking lots of sugary drinks, then you get then a very rapid rise in blood glucose levels. Now we know that high levels of glucose in the blood are what is called glucotoxic to the pancreas. So if your sugar levels are really, really high, you get a toxicity on the beta cells in the pancreas that further declines insulin production. And you get a sort of vicious cycle. So you've started off with high sugar levels, you've been drinking sugary drinks, that then makes your sugar levels higher, that then feeds back and inhibits insulin production, which makes your sugar levels go even higher. You're then more thirsty, you drink even more, your sugars go up even more, that again feeds back to the pancreas. So you get this, this vicious cycle. And that causes an acute deficiency in insulin that then leads to ketosis presenting. If you treat the diabetes, say with insulin, put them on a sugar-restricted diet, that will lower the sugar levels. It allows the beta cells to at least partially recover. And so then you may be able to withdraw insulin and manage the patient with tablets alone. So ketosis-prone type 2 diabetes is essentially a consequence of this glucose toxicity at the time of presentation. But I suspect that there's also underlying low levels of insulin anyway because of genetic factors. So Umang Chandna has said that his father has type 2 diabetes. On a scale of 1 to 10, how likely or susceptible am I also going to have this condition? Well, I think in part, Umang, that depends on your body shape. So you will have inherited a genetic tendency from your father. So if you put on a lot of weight, then the chances are that you get type 2 diabetes might be 7, 8, or 9 as you get older. But if you can keep yourself really slim and really fit, then you will reduce the likelihood that you get diabetes. Is there a genetic approach for the diagnosis of diabetes mellitus? Well, I've sort of discussed that. This was from Mrunal C. We don't need to do genetic testing in people with diabetes at diagnosis. You only need to think about genetic testing, say, from the monogenic forms, if things are just not quite fitting. So if it's not clearly type 2 and not clearly type 1, then you might think, well, could there be an underlying genetic cause? Anna Barrage has asked if insulin resistance is irreversible. Well, the answer to that is no. Insulin resistance is reversible. If you lose weight, you will dramatically enhance the susceptibility to insulin resistance. Shivam Mahajan has asked a very good question. How do some genes like DQA10102 confer protection against the development of type 1 diabetes? Well, as I said earlier, the genetic susceptibility to type 1 diabetes all comes through the genes that modulate the immune system. And basically what you're inheriting a tendency is that if you have are exposed to the environmental trigger, whatever it is, then your immune system will respond to that trigger by activating an autoimmune response. Now, some genes that you inherit will increase that immune risk, but other genes that you inherit decrease that risk. And it's the combination of the two if you inherit more genes that increase your risk and fewer genes that reduce your risk, then your genetic risk of type 1 diabetes will be higher. Both type 1 and type 2 diabetes are what are known as polygenic disorders. It's not just one gene that confers susceptibility or protection from diabetes. It's the interaction of many, many, many different genes. Why Asma Mishra has asked why hypertensive patients are at risk of developing diabetes. Well, that's because hypertension is associated with central obesity, it's associated with increasing age, and it's associated with insulin resistance. So it's not the hypertension per se that makes you at higher risk of developing diabetes, but it's the common factors that leads to the development of both hypertension and diabetes. Samjayat Ganguly has asked, how do colder climates influence type 1 diabetes? So yeah, I didn't explain that very well. So I said that people living in Finland are more likely to get type 1 diabetes. So if you believe, for example, in the viral hypothesis, then it might be that colder climates allow certain viruses to live and spread, whereas in warmer climates, they don't do so well. So we've certainly seen that in Europe with COVID, that there's been, for example, much less COVID in Greece, say, than we've had in the United Kingdom, although it's clearly much more complicated than that. Aiswara Santhu Sahunthala has asked about the relevance of regular physical activity for type 1 diabetes. Well, we do very much advocate physical activity in people with type 1 diabetes. It won't stop you getting type 1 diabetes, physical activity. It will reduce your risk of getting type 2 diabetes. But if you have type 1 diabetes, physical activity enhances your insulin sensitivity and can, in some parts, make your diabetes easier to control because you don't have insulin resistance to factor in. But also, just in terms of cardiovascular health in type 1 diabetes, it's better to be physically fit and active. What does low birth weight have to do with diabetes? Asks Divya Jampani. Very, very good question. And we don't totally know the answer to that. It's almost certainly to do with what's called programming. So there have been lots of studies done that have shown that babies of very low birth weight are at increased risk of getting the metabolic syndrome in later life. And it's really for mechanisms that we don't understand. One hypothesis is that it relates to later activity of the hypothalamic pituitary adrenal axis, that people who, because low birth weight has effectively been a stress during intrauterine life, that activates the HPA axis in some way, so that you just have slightly higher levels of glucocorticoids in your body that then getting central obesity as you get older, and then type 2 diabetes and hypertension, but it's quite speculative, that. Dipanshu Narang asks, what are your views on combination therapy in the development and in immunotherapy and stem cell therapy for type 1 diabetes? This is extraordinarily, to try and see the problem with those studies is that they have to be done usually in children and young adults. So you've got immediate ethical issues for a start. And of course, you are potentially giving immune modulating treatments to people who are not actually diabetic, because you're trying to stop them getting diabetic in the first place. So you're giving it to the treatment to the siblings to try and slow down the immune destruction of the pancreas. And it's really around trying to preserve beta cell function. So I mentioned earlier that 6% of people with type 1 diabetes have some retained endogenous insulin production. And if you've got that retained endogenous insulin production, then your diabetes is easier to manage. And so the thinking is going, well, if we can give biologic agents to people shortly after diagnosis of type 1, we can get a higher proportion of people who have got retained endogenous insulin and just make their diabetes easier to manage. I think it's extremely exciting, extremely interesting, but it's still very experimental. Stem cell therapy, obviously there are transplant programs for pancreatic islet cells for people whose type 1 diabetes is difficult to manage. Stem cells, I struggle a little bit more with, because that is quite a big dramatic intervention with really the long-term consequences not entirely clear. So I'm not sure myself I'd be in a rush to take stem cell therapy if I had type 1 diabetes at the moment. Danesh Gandhi's asked, what's the role of intermittent fasting in type 2 diabetes? So so obviously one of the main goals of treatment in the management of type 2 diabetes is getting people as lean and fit as possible. Now, if intermittent fasting is a method that works for you to keep your weight down and keep yourself slim, then I'm all in favor of it. I don't mind how people lose weight, within reason, obviously, as long as it works for them. The only thing you have to be careful with intermittent fasting is if they're taking sulfonylurea agents or insulin, because obviously then there's a risk of hypoglycemia, and that needs to be discussed with the patient and their treatment modified on fasting days. Anat Braj has asked, does prolonged use of insulin cause insulin resistance? I'm not aware that it does. Type 1 diabetes. And as I said earlier, these are not the cause of the autoimmunity, they're just a marker of it. And the GAD antibody test, it's a straightforward immunology test. And if you've got somebody who's diabetic and they've got very high titers of GAD antibodies, then that is an indicator that it is type 1.
Professor Mark, I'm sorry to interrupt, but we are already done with the timing. So maybe if you can just take a few last questions before we close.
Okay. What can I do? Sanja's asked, how can we test for insulin resistance, and what tests can be done in pre-diabetic patients? Well, in one sense, you don't actually need to test for insulin resistance, because if you've got somebody that's got central obesity, that's a very good biomarker for insulin resistance. So if you're carrying weight around your tummy, then you will have a degree of insulin resistance. If your sugar level is, if your fasting glucose level is elevated in somebody who's overweight, that again is a marker of insulin resistance. You can though measure insulin and C-peptide levels, and you can do, there's a sort of an equation called HOMA modeling, H-O-M-A, that allows you to put in what the fasting glucose is and what the insulin level is, and you can work out the degree of insulin resistance. But I've never ever felt the need to do that, because I say it's usually pretty obvious that somebody is insulin resistant. Vance Shah has said, is there any correlation between genes that make you susceptible for obesity and genes that code for better beta cell function? No, I don't think there is. I mean, I think we inherit from our parents these different genes almost independently. But, you know, you say you can be, you know, and you can imagine there's different patterns. You can inherit genes that make you more likely to be obese, but that give you a good pancreas, which means that you're less likely to get diabetes. Conversely, you can get you can inherit a tendency to obesity and have not good pancreas function genes, which makes you more likely to get diabetes. So they are separate. Oh, now, yes, Bhavya Teja Raya Varapu has asked a very important question just about my graphs. So those graphs I was showing with the age of onset of diabetes and the decline in insulin function, I had them as straight negative slopes. Those are stylized graphs. It's not like that in real life. There is a gradual decline in pancreatic function as you get older, but it won't be a straight line. And I suspect, for example, Bhavya's asked if it could be exponential. I don't think it's exponential and it's faster in childhood. It probably speeds up, if anything, as you get older, because of the effects of environmental factors like alcohol and drugs. Somebody mentioned beta blockers earlier, steroids, all these sort of things, you know, may have a negative effect. So those graphs, don't take them as literal graphs. They are just stylized representations, just to try and better explain the concept. And then maybe I'll take this last question. What from Palab Sarkar? What is the absolute finding that differentiates between type 1 and type 2 diabetes for diagnosis? Well, what I do, if I have got a new diabetic at the time of diagnosis, and I don't know if they're type 1 or type 2, then I will measure the antibodies. Because if the antibodies come back very strongly positive, then that's type 1. If the antibodies come back very weakly positive, then it may not be absolutely certain, although it's more likely to be type 1. And if the antibodies are negative, then I'm going to be thinking it may be more type 2. But remember as well, it's not just about the diagnosis. You've got to think about things like ketones, because if they've got ketones present, then that means whatever the etiology, that at that particular point in time, they are not making enough insulin. So you just have to bear that in mind as well. And I think, Priyanka, I'll probably stop there.
Thank you, Professor Mark. Thank you very much for taking this informative session for the participants. I understand there are a lot of questions right now which are still unanswered. We have more than 292 questions right now, but we have also time limitations. So, Professor Mark, can we just send these questions to you and you can have a look at them? But if you can answer the important questions, we will share them further with the participants later through email.
Okay, yeah, no problem.
With this, any closing words you would like to say to the audience?
No, not at all. Thank you so much for your time and attention. I hope you've found that interesting and informative. And as I say, I just would encourage you just to, when you see somebody with a new presentation of diabetes, just think to yourself, why is this person diabetic?
Professor Mark, so before we close, I would like to tell all the participants here that a recording of this session and the certificate of participation will be shared with you on email in a few days. And also we will be coming up with our next interesting masterclass by another Davidson editor, Dr. Richard Hobson, on 3rd of September. So you can keep connected to the social media pages of Elsevier India for further updates. Thank you once again, Professor Mark, and thank you all the attendees here for giving your time. Thank you.